Sorry, there was, yeah, you're safe, there's no terror attack. So I invite now Professor William Griffiths from London to present his talk. I know he's running short of time and he has a next session to go to. Please commence. Thank you.
Thank you very much indeed. As ever, if anybody would like a copy of my presentation, all they have to do is email me on that email address, willhg@pm.me, and I will very happily in the next few days email you the full presentation. Thank you very much for inviting me to speak not just once but 5 times over 2 days. This is the second of those. And I'm going to talk about safety in anesthesia. And I'm going to start with my assertion that as anaesthetists, we tend to worry quite a lot. I think we worry more than other specialities. And I think in general that regional anaesthetists worry more than general anaesthetists. We spend a lot of our time concerned about the things that may go wrong with our patients. So I'm going to ask you, as regional anaesthetists, what you worry about the most. And here's your choice. A, local anaesthetic toxicity. B, nerve damage. C, bleeding. D, infection. E, death. Or F, the Cricket World Cup. No, I'm joking about the Cricket World Cup. Of those 5, you're only allowed to put your hand up for one of those 5 that you worry about the most in your practice as a regional anaesthetist. So hands up who worries most about local anaesthetic toxicity. Okay, not many, a couple. Nerve damage. Oh, lots of people worried about nerve damage. Bleeding. Not many people. Just a couple there at the back who worry. Infection. Yeah, after my talk yesterday, you should be worrying more. Death. Yes, a man at the front go, yes. Okay, so, second question, and you'll see why I'm asking this question. Is regional anesthesia associated with a higher or lower incidence of peripheral nerve damage than general anesthesia? And your choice is higher, lower, or about the same. So who's going for higher incidence of nerve damage? Okay, well, not that many. Okay, who's going for lower? Ooh. And who's going for about the same? Okay, you've got tired with putting your hands up. But look, my wild guess is that we're most worried about nerve damage, and I think that's borne out by the people who put their hands up straight away. I think a lot of, it's kind of, we do worry that it may be a little bit higher, maybe it's the same. We worry that by doing regional anesthetics, we expose our patients to risk. But is it? And the first question to ask is, who damages more nerves, surgeons or anaesthetists? And if you go to this paper from Regional Anaesthesia and Pain Medicine, you will find very conclusively that it's the surgeons by a long chalk. So shoulder arthroscopy up to 10% nerve injury, open shoulder surgery up to 8%. If you go down the bottom, elbow replacement is associated with an incidence of nerve injury of up to 20%, and an incidence of permanent nerve injury of up to 10% of patients. We are mere amateurs when it comes to damaging peripheral nerves. The surgeons are the experts. But also you have to realize that just giving a general anesthetic is associated with nerve injury as well. This is a rather old paper from the amazing Mark Warner from the USA, but he demonstrated in it the incidence of nerve damage associated with just giving an anesthetic of any sort is about 1 in 2,700 incidents of ulnar neuropathy. And even though those are old data, this is supported by more recent data, albeit 10 years old, of retrospective studies of huge registries that show that the incidence of nerve damage just associated with giving a range of patients a general anesthetic is around 1 in 500 to 1 in 3,000. And this study then analyzed statistically what particular features were positively associated with nerve damage. The patient features were diabetes mellitus and hypertension and tobacco use. And interestingly, epidural and general anesthesia were independently associated statistically with nerve damage, but not peripheral nerve blocks. Believe it or not, peripheral nerve block in this study was not an independent risk factor for peripheral nerve injury. And this is borne out by a fascinating paper published this year in Regional Anaesthesia and Pain Medicine that I would strongly encourage you to look at if you have the time. Yes, it's a retrospective registry study, it's not a prospective study, but the results are fascinating and absolutely delightful if you're a regional anaesthetist. They looked at 10,000 patients undergoing surgery, and they were looking not for permanent nerve injury, but for new numbness, tingling, or weakness that may suggest nerve damage of some description. The overall incidence of nerve injury, that way defined, was 1.2%. In patients undergoing peripheral nerve block, it was less. It was 0.9%. In those without a peripheral nerve block, it was 1.4%. In those undergoing general anesthesia, it was 1.4%. And those not undergoing, it's the wrong way round. It seems to be that those having the peripheral nerve blocks have got a lower incidence of nerve injury than patients undergoing general anesthesia. And if you look at what sort of patients are suffering the highest incidence of nerve block, you're looking here at people undergoing, believe it or not, abdominal surgery because they're having transversus abdominis plane catheters or injections. The factors that tended to make it more likely that you would get peripheral nerve injury were these: just having a general anesthetic, being a younger patient, and having an ASA physical status less than 3. And this is the astonishing figure from that paper. Supplementing a general anesthetic with any regional anesthesia decreased the odds of nerve injury, decreased it by 61%. So you're actually, in a way, protecting your patient from nerve injury by giving them a block. It's difficult to get your head around this, and we haven't got the time to discuss exactly why this may be the case. But papers tend to suggesting that you have more nerve injury if you don't have a block. Okay, we know surgery damages nerve. We also now know, increasingly, we understand that general anesthesia is associated with nerve damage, but we have to accept that regional anesthetists can also damage nerves, and there are lots of ways we can do them. We can give the wrong drug. We can damage the perineurium and let local anesthetic into the fascicle, and local anesthetic in itself is toxic. We can inject into the nerve fascicle. We can damage the nerve fascicle with the needle. We can cause compression by bleeding. We can damage or cause vasoconstriction in the blood vessels. We can cause, or we can be associated with inflammatory changes locally or elsewhere in the body by doing a block, or even by not doing a block, Pastor Turner. What we tend to obsess about are those three, the things that we can cause damage to that nerve by putting the needle near the nerve, by bumping into that nerve, and that's undoubtedly true. And that's why we believe, or it is very tempting to believe, that ultrasound has to be safer from the point of view of injuring nerves, because we can see the needle and we can see the nerve if we know what we're doing. Well, ultrasound is safer, I genuinely believe. It gives you a lower incidence of vascular puncture. I think that's been definitively demonstrated. It gives you a lower incidence of local anesthetic systemic toxicity. That's been proven as well. It gives you a lower incidence of pneumothorax for those blocks that you're performing around the clavicle. That's been shown as well. And it gives you a lower incidence of peripheral nerve injury, only it doesn't. We can't prove that's the case at all. We want to believe it. I believe it. We can't show it. I can't show it. If you look at the most recent comprehensive review of this back in 2015, the ASBRA Practice Advisory on Neurologic Complications, they say there are no human data to support the superiority of one localization technique over another with regards to reducing the likelihood of peripheral nerve injury. Although they go on to say that ultrasound technology at that time, and at this time as well, does not have adequate resolution to discern between interfascicular and intrafascicular injection. It may be in the future that our technology will allow us to differentiate between those two, but it is not there fully at the moment. So I'm afraid, a disappointment to the ultrasound devils, that there's no evidence that ultrasound is safer than nerve stimulation from nerve injury point of view. And I'm afraid to say Those of you who are older, who are as old as I am, and remember before the times of nerve stimulation, there's no actual evidence that nerve stimulation was any safer than the paresthesia technique from the point of view of nerve damage. We've got no evidence. And you can look as recently at this publication from the end of 2018 that looked very carefully in a retrospective single-center analysis comparing nerve block complications using peripheral nerve stimulation and ultrasound. There was no difference in the incidence of nerve injury. So, okay, we worry about these things. We worry about them a lot, and that is very reasonable. They're going to happen, but our job as anaesthetists is to minimize their incidence, to do what we can to make them as unlikely as possible for our patients. Many of you may know the difference between safety 1 and safety 2, and I think it's important to look at safety in this context when we look at rare events that happen to patients. Safety 1, the traditional approach to safety, was that we try and make sure that as few things as possible go wrong, and we do this by looking at the rare untoward events and getting completely obsessed about them and analyze them and look at them and find out what happened and see if we can blame the person who did it. That's safety 1. But safety 2 shifts that paradigm completely and says, let's try and make sure that as many things as possible go right. We analyze the system not for looking at things that go wrong, but for looking at how things go right and how the system adapts to ensure that things go right. So if you look at this bell curve here, these are the rare untoward events. These are all the kind of normal events that happen every day, and these are the really brilliant, successful, wonderful things that happen here. Safety 1 is obsessing about this small end of the curve. Safety 2 is looking at the rest of what happens to us, what happens to our patients, and looking at why it tends to go right. This is Alan P. Winnie, inventor of, amongst other things, the interscalene brachial plexus block, the subclavian perivascular block, the 3-in-1 block, an absolute brilliant and now sadly dead genius who had a number of quotes, and this is the quote that you don't find written down because I think it is one of his most valuable quotes. It's not the prick at the distal end of the needle that does the damage. And what he's trying to say in that rather rude phrase is don't obsess about the needle tip and the nerve too much, because it's the person holding the needle, their approach, what they are doing, the way they are performing, the team within which they are working, that is the person that's going to make that block successful or damage the patient. It's not the prick at the distal end of the needle that does the damage. So I wrote down, this last minute or so, what requirements you need to make things actually go right. Not obsessing about things going wrong, but to make things go right for your patient. Everybody standing up on these podia on these 3 days of this brilliant meeting are going to say the same things. I'm sorry, guys, you need a detailed knowledge of anatomy to perform regional anesthetics. There's no way you can avoid that. You need to know a bit of physics of the ultrasound machine and the nerve stimulator. You need to know a little bit of pharmacology. That's quite useful as well. If you're a trainee, you need to be trained really well, and you need close and good and supportive supervision for as long as you are in training until you become completely confident. You need good hand-eye coordination, particularly for the use of ultrasound. You can't get away with it. There are some people who are just naturally clumsy. They should not be doing regional anesthesia. They should be cardiac anaesthetists where their hands cannot do any harm at all and they can use their brains to their heart's content all day. You need to be gentle. Have you seen people who go in with needles like that? No, you just need to be gentle. You need an understanding of ergonomics, screen, patient, you, in a line, so that you're comfortable with what you're doing. You're not looking from one side to the other with your neck turned to one side. You need to understand the ergonomics. Coming back to yesterday, you need good asepsis. Yes, you may not like checklists, you may hate them, but actually they're really supportive to safe care if you believe in them and you use them properly. You need to practice, then you need some more practice, and then you need even more practice after the more practice. You just need to practice. It's a numbers game. You need to do this a lot. You can't be a good regional anaesthetist doing 5 a year. You can be a good regional anaesthetist doing 5 a week, but not 5 a year. You need to know what to do when the wheels fall off. when things go suddenly wrong, you need to know what you're going to do, and you need to practice what you do. How often do we say, well, I know what to do when there's local anesthesia, systemic toxicity, but how few of us have a simulation where we say, where's the intralipid, and actually get it and bring it into the room and see how long that takes. You'd be surprised if you simulate these things on however low a fidelity simulation, how long it takes. You need a friend by your side who is not in awe of you and is prepared to say, Professor Harrop Griffiths, I think you're blocking the wrong side, because they are your best friend. You need good teamwork. Now and again, you need a little bit of luck. And finally, you need a plan B when your block doesn't work, because however brilliant you are, sometimes it won't work. You need a plan C when the general anesthetic doesn't work, but that's for this evening's talk. You need a willingness to pull out when the going gets odd, as it will get odd. You need the presence of humility, and you need an absence of pride. You mustn't get that error where you keep on thinking, I'm the best, I can do the block. You just back out. Be humble and don't be proud. You need to keep a sense of proportion, because anesthesia is safe. Surgery is dangerous. Death after elective surgery, 1 in 200. Emergency surgery, 1 in 25. Out of hours emergency surgery, 1 in 20. Emergency laparotomy, 1 in 10. Emergency laparotomy aged greater than 75 years, 1 in 5. We are safe. We're well safe. Very finally, I'm sorry I'm overrunning, this will be 30 seconds. A quick tale, because we love stories. Gordon Ewing, a Scotsman, 51-year-old man, rather large, BMI of 40. He was given fentanyl, thiopental, and succinylcholine. They looked in with a Mach 3 laryngoscope, couldn't see very much, so they put a laryngeal mask airway in. Great ventilation, but they were determined to get a tube in, because he had a history of reflux. So they took that out, and they put in an intubating laryngeal mask, and then they tried to stick a size 8 tube down, and it wouldn't go down. So they tried a size 7, and it went in, but there was bleeding from the oropharynx. And they got obsessed about the bleeding from the oropharynx. So they took the ILM, and they took the tube out, and they put a Cook airway exchange catheter down through the tube so they could ventilate them when they took everything out. Then they put in another ILM, and then they pulled out and then they couldn't get a tube in. So now they've just got a Cook catheter in. And they start ventilating through the Cook catheter. They use high-pressure oxygen ventilation, and he blows up like a balloon. Massive subcutaneous emphysema, huge swelling, loss of airway, cardiac arrest, death. True story. What was his operation? Little finger. He had a broken little finger. Sometimes, often perhaps, regional anesthesia is an awful lot safer than general anesthesia, even though it has got additional risks. Thank you very much.